We had been discussing some of the principles of organ allocation. And we covered the matching of quality of kidneys to longevity of the potential recipient through the EPTS score and the KDPI. So now we are going to finish up our discussion around how a wait list is managed. And we talked about the fact that it's based on point system, and the general principles of that point system are that highly sensitized patients get higher points. If you have a zero antigen mismatch kidney and recipient pair, that's prioritized. If you've previously been a living organ donor, that's essentially equivalent to being on the wait list for about 4 years. So you get about 4 points for being a prior kidney donor. And then there is the priority given to proximity to the donor. And that proximity is not based on where your house is. That proximity is where was the recipient evaluation done and where is the procurement of organs done. Okay, it's not where you physically are living. And then the last sort of pool to see the kidney is the candidates that live outside of that 250 mile radius to the procurement hospital. Okay, again, it's based on points. Wait time, 1 year of wait time provides 1 point. Said differently, 1 day of wait time gives you 1/365 or 1/365th points. Okay, now you get to start accruing wait time once you're actively listed, okay, or you have started dialysis. We can backdate your wait time to the start of dialysis. So again, your wait time is determined by the longest of the two. Okay, so if you've been on dialysis for the last 10 years and for some reason you cannot be on a transplant list, let's suppose you were having a problem with drug addiction, and then that resolves, and then you become active on the wait list because you've been able to break that barrier to transplantation. Then on the day of listing, you will get 10 years worth of wait time from being on dialysis for 10 years. So automatically you'll jump to the front of the waiting list. Now you cannot backdate to when your GFR was less than 20 mils per minute. If you're not on dialysis, the wait time starts when you're actively listed. Even if you've been less than 20 for 10 years, you do not get credit for that eGFR being less than 20, okay? So you can get backdated for dialysis start times, but in the pre-dialysis patient, your wait time starts when you're actively listed. Now, there was a period in which patients who were of African descent or who self-identified as Black and were disadvantaged by the race-based equations for estimating GFR, there was a period of time in which this wait time was recalibrated around the time of that shift in eGFR estimation, but that window is gone. So there was, again, this recalibration phase. Now we're in the sort of, let's call it status quo. You get backdated for dialysis start time, and then your time starts when you're active on the wait list in the pre-ESRD patient. You also get points for being sensitized. Remember, we went over what a panel reactive antibody is. That is based on knowing something about the HLA identities within our donor pool, as well as a Luminex study, looking for preformed antibody. You can then calculate, that's what the C stands for, the panel reactive antibody to that donor pool. And so based on that, you can say that if you are incompatible with 20% of the donor pool by virtue of the fact that you have a preformed antibody, you get 0.08 points. On the other hand, if you are incompatible by virtue of preformed antibody with 100% of the donor pool, then that would be equivalent to being on the wait list for 200 years. So you got 200 points for being highly sensitized. That's important because obviously if you're highly sensitized, unless you're at the top of the wait list, you're not even going to be attempted to be matched with an available donor. And so again, it makes sense to give those individuals who are highly sensitized an option to be evaluated for compatibility to an organ every time that organ hits the scene. Okay, that highly sensitized pool gets to be investigated for compatibility. Again, if you're a previously living donor, you get 4 years essentially of wait time. Pediatric candidates will get some extra points according to their age, the quality of the kidney, and the rightness of fit between the donor and the recipient. Remember, I told you you got some extra points for matching at HLA-DR. DR is, remember, class 2 HLA, right? Class 2 HLA is expressed on antigen-presenting cells. Class 2 HLA matching seems to have reasonable predictive value in long-term allograft function. And so again, if our goal is to maximize the good, right? If I do a transplant, I want the optimal outcome of this kidney going to a really, you want longevity matching between the kidney survival and the patient recipient survival. And matching at DR, because it has predictive value in long-term allograft function, would be an attempt to, again, maximize the good. There was also, so again, if you're matched at 2 loci in DR, you get 2 points. It's as if you're on the wait list for 2 years, okay? So you can see that your points are varying in time. When a kidney becomes available, these match calculations are done, and so you can spontaneously go up by 2 points. In another instance, you'll be 2 points shy. So you can see there's some dynamic element to matching, and then there's a static or predictable element in matching. For instance, how many days have you been on the wait list? Okay, there used to be matching points for the B locus. This, because it had predictive value in allograft survival, this was taken out because it disadvantaged African Americans. Okay. Medical urgency can allow for some exceptions where people can go to the top of the wait list, even though their points may not be high. A classic example of that would be an individual who is exhausting access options and is, for instance, not a candidate for transition to PD, right? They're working on a transhepatic catheter as their last access because they've exhausted all points on their arms and even their femoral access points. And then again, they had, let's say, a bowel surgery with adhesions and they're not a candidate for PD. A patient like that could theoretically go to the top of the wait list. Okay, let's now look specifically at evaluating the recipient. So when you go to transplant clinic and you are trying to evaluate a patient for candidacy for transplantation, these are some of the elements in trying to evaluate the recipient. Now, I'll give you the background, however, as you're doing all of these, let's say it distills down to a bunch of check boxes, somewhat mind-numbing check boxes. I used to do recipient evaluations some time ago. And I used to tell Miguel, earliest convenience, please get me to do other things, because it's basically bean counting. Have you done your echo? Have you done your colonoscopy? Can you walk a flight of stairs? all of that was, not the most stimulating endeavor for me. Okay, I'll say for me. All right, so but what you're trying to do in that checkbox is to look at survival. Okay, or I'm gonna make this death, okay, as my y-axis. Okay. Death, when patients are dying, that death rate starts to, increase in time, right? So this is time on my y-axis. Okay. And what you're doing in these pre-transplant evaluations are trying to parse this statistical relationship. When you undergo a transplant, your risk of dying compared to someone staying on dialysis is actually increased in those first few months. Well, why is that? Well, you are undergoing a surgery, and most dialysis patients have and CKD patients have cardiovascular morbidity going into a surgery. You're blasting them with immunosuppression, and so there are risks of perioperative infections as well as opportunistic infections. And so you have to accept that compared to somebody who's just waiting on a wait list, there's an increased risk of death in that first few months. You're hoping that if you've chosen a reasonably healthy patient, there's a place down the road in which those lines cross, where your survival rates or your death rates, we'll keep it on death rates, are less by having undergone a transplant than staying on dialysis. So we think that transplant in general enhances survival when compared to patients staying on dialysis. Okay? Now, the more morbidity that you have, the further down the road that you see this crossing of the survival curve. If the patient is extremely sick, you may never see these curves cross. So that's the calculus that you're trying to achieve when you're doing a pre-transplant evaluation. Turns out that in a standard patient, these lines, in an average patient, these lines cross at around 6 months. In the classic patient who gets a high KDPI kidney, remember, high KDPI kidney is a kidney that is of lesser quality. It doesn't necessarily correlate with a sicker patient, but generally patients who accept lower quality kidneys are also high EPTS score patients. Remember, EPTS, expected post-transplant survival? That's attributes of the recipient, okay? So high KDPI kidneys are generally high or kidney transplant recipients are generally also high EPTS score patients, okay? The lines do cross with that sicker patient population, but it's more around 12 months that those lines cross. Okay, so there is a survival advantage for the typical high EPTS patient who's willing to take a high KDPI kidney. But you have to be honest that survival is blunted by that underlying comorbidity of the patient. Okay? All right, so this is the calculus that you're trying to achieve, thinking about high KDPI kidneys, also thinking about the EPTS score of your patient, and this laundry list of checkboxes in pre-transplant clinic. Okay? So, again, we are trying as much as possible to achieve preemptive transplant listing, because the earlier you get on the transplant waiting list, the earlier you begin to accrue wait time and therefore minimize dialysis time. Okay, let me make that point too. Remember, EPTS score is driven by only a handful of factors: age of the patient, time on dialysis is another important factor. So the more years of dialysis, the worse your post-transplant outcome. And so that's another reason to try as much as possible to get patients preemptively listed, because you want to try and shorten that dialysis vintage, is what we call it, because that impacts post-transplant outcomes. Okay, so again, the earlier you list, the earlier this intersection between survival curves will occur, because you're having healthier patients that are receiving transplants by virtue of a shorter dialysis vintage. Does that make sense? All right. Okay, here's the routine workup. There's different, transplant center specific criteria. So this is just in broad strokes some of the principles that many institutions utilize. BMI is in general a metric that has been more liberalized over time, because we're having higher BMI recipients more commonly. And also there have been studies that have shown that transplantation in higher BMI patients still does translate to better survival rates than staying on dialysis. Okay, so this is driven by virtue of, again, higher BMI recipients being more common, as well as studies that show that even transplantation in higher BMI recipients does seem to confer a survival advantage when compared to staying on dialysis. However, there are increased rates of delayed graft function and wound complications in higher BMI patients, because there's more tension on that transplant incision. That would be one, rational argument of why you have more wound complications. Okay. Every center determines what their cutoff is. I don't remember what our current cutoff is. It's somewhere around 35, maybe even higher than of late. Okay. Routine labs, blood typing. We obviously get some, routine stuff like PTHs and pregnancy tests. Why PTH? That's not going to be a barrier for transplant, but that will help you in the post-transplant setting decide on whether you should treat with Sensipar while follow for phosphate wasting. If a patient has residual kidney function, you want to know how much proteinuria they have going into transplant, so that in the post-transplant setting, when they may have some residual urine from the native kidneys, we can not get overly concerned about proteinuria, because again, that may be derived from the native kidneys and not from the transplant. We get a variety of serologies, including some things that are relevant for patients from endemic areas. So we may get, Chagas testing in somebody from Central America. Strongyloides has also become more commonly assessed. And I would say more recently, these are becoming even more liberal in our testing. Some people are espousing even universal testing for strongyloides in particular now, especially in our area of the country. We give vaccinations to those patients that are, that seemingly could benefit from, an MMR vaccine. We're checking for CMV, EBV, because that's relevant to predicting patients' post-transplant risk for CMV, as well as Epstein-Barr virus and post-transplant lymphoproliferative disorder, which is usually driven by EBV. So that would obviously make sense to check for pre-transplantation. Other infections are pretty obvious why we would want to diagnose those pre-transplant. We'll of course look for HLA, preformed antibodies to HLA. That will feed forward to the calculation of CPRA. We'll do drug screening. I think at Parkland, if your drug screening for marijuana is positive, that would be something that would hold up the transplant listing. At UT, that is not something that would hold transplant listing. So each center will treat that according to their center-specific criteria. Chest X-ray is often just for latent TB diagnosis. We'll evaluate for aneurysms in those patients that have risk factors for aneurysms. We'll do some baseline cardiac testing, which we'll talk about a little bit more in the subsequent section. Routine cancer screening is performed in patients according to age-appropriate criteria. You'll also consider cancer screening in special populations, such as a patient who has a history of cyclophosphamide exposure and hematuria. If you've had lupus nephritis and previous cyclophosphamide exposure, you might consider evaluating with a CT urogram for, transitional cell carcinoma screening. So you can, there is a bit of nuance. This is not common, but if you have somebody who has aristocolic acid nephropathy, Peter Van Buren went over that as one of the causes of chronic interstitial nephritis. There's a risk of cancers of the urinary tract. You might consider, again, some specific cancer screening in certain patient populations according to their risk factors. Frailty assessment is also standard practice, and there's a variety of tools for assessing frailty. Now, workup of CAD is controversial, okay? There's American College of Cardiology guidelines that are published on pre-transplant screening. But even though you would think the guidelines will provide more uniformity, each center still has their center-specific criteria of who needs to get stress tested, who needs to go to cardiac catheterization. And this is an area of controversy and sometimes, fights. But I would say that each center has their own criteria. Our center, UT Southwestern, in particular, is fairly aggressive about evaluating screening for asymptomatic coronary artery disease. And this is controversial. There's even a randomized controlled trial looking at the value of coronary artery disease screening with left heart catheterization in asymptomatic patients. Even these patients had positive stress tests in this randomized controlled trial. If I remember correctly, I think it's called ischemia CKD. And that study showed that screening asymptomatic patients with left heart catheterization who have a mildly positive stress test, that's not patients who have LV dysfunction concerning for triple vessel CAD or left main, showed no benefits in terms of patient survival and an increased risk of stroke in patients that were randomized to left heart catheterization. So detectable downsides. But still, there are some institutions that still push for left heart cath in asymptomatic patients.
Their argument is you don't know what's going to happen post-transplant, theoretically going to live.
The argument is that the surgeon wants it. That's the argument. They're unwilling to do a surgery in somebody they think is high cardiovascular risk, even though evidence would show, even in the patients transplanted, there's no clear evidence of benefit. Okay. And there's even, when I was a medical resident, there was an old study looking at patients going for AAAs and PVDs, so high cardiovascular risk burden, and screening and intervening on asymptomatic patients. Even in that patient population, there was no evidence of benefit. So this is not a new finding. We've known in a couple of disease populations that intervening on people who are asymptomatic is not, it seems right, but it's just not borne out in the literature as a clearly beneficial thing to do. All right, so there are obviously risk factors. You can use your judgment on how to define those risk factors. Some would say, in an IgA patient who, has been on dialysis for 1 year and is 20 years old, asymptomatic, get an echo. They don't need any stress test. There's so much variation in a center's policies. Here's one way to approach it. Do some cardiovascular risk assessment. Usually if you have diabetes, many of those patients, regardless of age, get their battery of cardiovascular risk testing, okay, stress testing. And I think in our institution, if you're diabetic, go straight to left heart cath, I think, in our institution, okay? Don't quote me on that, but I believe that's the case. Intermediate risk, again, I don't think I'll go over this. I will just reiterate that even the non-invasive testing, dobutamine stress testing, exercise dobutamine, and thallium stress testing, it's not clear. There's some signals that one is a little bit better than the other, but it really is not clearly known which is the right stress test to do in a patient. Okay. All right. Cerebrovascular disease is also a risk for our patients. You might consider using, physical exam findings, but this is horrible in predicting cardiovascular risk. So each center will decide whether, to screen with Doppler testing. And even then, asymptomatic, intervening on a coronary stenosis, artery stenosis. That too has never been shown to clearly benefit patients. Okay. ADPKD testing might involve screening for Berry aneurysms, even in asymptomatic patients. I think many centers are going to do that. But there's some controversy in that as well. Peripheral vascular disease has some unique considerations because remember, the allograft goes down in the pelvis and is tethered to the iliac vessels. Okay, so if you have porcelain vessels, just totally calcified vessels, you might get into the abdomen and find that there is logistically no place that I can anastomose this kidney. And so patients are often getting non-contrast CT scans, looking for vascular calcification in the iliac vessels. And the surgeon reviews that and determines, logistically, we cannot list this patient because their vessels are so heavily calcified. There's no place to tie an allograft in. So that's usually a non-contrast CT that's done in select patients according to risk factors. Okay. You can use pulse assessment as well to make some of those determinations, but often it's based on a set of criteria that an institution leverages for triaging patients. All right, pulmonary disease might be, you drive clinical decision making based usually on symptoms and PFTs, and someone makes a judgment call, perhaps with the assistance of a specialist. Is this a contraindication to transplant or not? Asthma that's so severe they keep coming in for asthma exacerbations. Certainly COPD can be a limitation, especially if you're on chronic O2. Most centers will strongly encourage smoking cessation. There is a detectable increase in risk of death post-transplant in patients who are smoking, but centers will decide whether that's an absolute contraindication or not. If I remember correctly, David Wojciechowski mentioned that marijuana is not a contraindication, but tobacco smoking is a contraindication to active listing at our UT program, I believe. Okay, so again, it's a serious risk that many centers take in listing patients. GI disease might be worth considering as for screening. EGD might be considered in somebody who has prior peptic ulcer disease. You remember that many patients are supposed to get a repeat EGD, making sure an ulcer is not cancerous, but often is sort of not prioritized. This is the patient population you would prioritize that because of course there's an increased risk of cancer after transplantation. Cholecystitis, if you've had cholecystitis in the past, some people are considered for cholecystectomy because again, the thought is with immunosuppression, we don't want you to develop cholecystitis again. Diverticulitis would be another instance. If somebody's had repeated bouts of diverticulitis, they might be triage towards partial colectomy in order to resolve that active or that risk of infection post-transplantation. If you've had chronic liver disease, then we screen for hepatocellular carcinoma with imaging and AFP testing. Urologic disease testing might involve cystourethrogram or urodynamics if a patient has a history of abnormal urinary tract, including recurrent UTIs. I mean, I know all of you have managed patients in the transplant service with recurrent UTIs, and obviously that has a huge amount of morbidity for the patient. And we do our best to try and find risk factors for that, but you can see that that is really imperfect in predicting future complications. Cystoscopy with bladder cytology might be considered in patients, as I mentioned, with certain risk factors. Cyclophosphamide, analgesic nephropathy, or uricolic acid nephropathy would be risks for transitional cell carcinoma. Bilateral nephrectomy can be considered for patients who have analgesic nephropathy, uricolic acid nephropathy, because there's a risk for, cancers of the upper and lower tract in those conditions. Tuberous sclerosis, which we'll talk about when we talk about cystic kidney diseases later in the year. That's a disease that arises from a mutation in a tumor suppressor gene and has a modest risk of malignancy. Usually these are hamartomas without malignant potential, but some of these, there's a detectable increased risk of malignancy, even though it's quite modest. Von Hippel-Lindau obviously is a risk of significant risk of cancer. You'll recall this is also a mutation in tumor suppressor gene. They have multi-system manifestations, including pheochromocytomas, recurrent renal cell carcinomas, tumors of the CNS, and also the retina. Extensive cystic kidney disease, acquired cystic kidney disease. This is not the PKD patient. Patients who are on dialysis for prolonged periods of time, 10 years of dialysis, for instance. If you look at their native kidneys, many of them have these really impressively cystic kidneys, right? They're totally replaced by kidney cysts. And you might be tempted to call them ESRD from PKD, but uniquely, their kidneys are small and cystic and polycystic, as opposed to huge and polycystic, okay? That is called acquired cystic kidney disease. We don't know why that happens in patients with prolonged dialysis vintage, both in hemo and peritoneal dialysis, but it does happen. And there is a detectable increased risk of renal cell carcinoma in that patient population. And so those patients might also be considered for bilateral nephrectomy, okay? It's also complicated to try and screen post-transplant for RCCs in these patients because they just have so many cysts. Some of them have hemorrhages in them, so they look solid on cross-sectional imaging, CT scans. And so again, it's really it's something that we consider in those patients. Recurrent pyelo might be considered for bilateral nephrectomy. Those young patients with, let's say, podocytopathies, the genetic mutations of podocyte proteins might be having failure to thrive because they continue to manifest massive proteinuria. So that might be an individual you might consider bilateral nephrectomy in, or in patients with PKD who have early satiety and weight loss. They may be considered for nephrectomy or unilateral nephrectomy to make space for an allograft to be put in if you have massive kidneys that might be in the way when you're trying to place the allograft kidney in the lower pelvis. Most patients with PKD do not undergo nephrectomy. Okay, that's a minority of patients. Okay, those patients with intrinsic renal disease, like lupus, they need to be quiescent before active listing because you don't want to transplant a patient who's going to develop recurrent lupus. Or if they're having, recurrent admissions for pericarditis, that would be a patient that you would be hesitant to list for transplantation. So we want them to be quiescent with modest immunosuppression pre-transplantation, right? They shouldn't be on, 3 grams of mycophenolate to keep them from having recurrent bouts of pneumonitis, right? Interestingly, patients on dialysis seem to mellow out in terms of their lupus activity. We don't understand why that is. Simplistically, we think of dialysis or ESRD being an inherently immunosuppressing condition. And so we certainly see patients who are really severely out of control. But then when they even get to advanced CKD, I've seen patients start to mellow out once they got to CKD 5 and or on dialysis. Okay. Similarly, vasculitis would want quiescent on minimal immunosuppression. Anti-GBM is another form of vasculitis, small vessel vasculitis. Most of those patients, I think we talked about this at the tail end of our conversation last year when we're covering GNs. Most anti-GBM patients, even if they're not immunosuppressed, let's say they, our patient at CUH who's got, ESRD from anti-GBM within the last year, even if she was not on immunosuppression and you checked an anti-GBM, most of them spontaneously remit, okay, and don't recur. So that's unusual for anti-GBM to recur, okay? There's a different type of anti-GBM, which we talked about, that can occur in the Alport's patient. We'll talk about that another day. FSGS is your GN with one of the highest rates of recurrence. You might consider the C3GNs and the atypical HUSs and the dense deposit diseases even higher, but those are rare. FSGS is much more common than these disorders of complement regulation. So FSGS is the one we think of mostly as a disease with significant recurrence rates that can affect the allograft function. IgA actually recurs in most patients. So most patients post-transplant, if you biopsy them for cause or for, as for surveillance, you'll see IgA deposition in the kidney in 70% of patients, but it's usually of no clinical consequence. But in FSGS, you have more consequential recurrence risk because it can result in allograft loss and a need to resume immunosuppression and apheresis, etc. Okay. Risk factors for disease recurrence would include those patients who already exhibited recurrence of FSGS post-transplant. If you consider retransplantation, the predominance of those patients will recur again. And so many centers will say, we're not going to list you again because of your death or your allograft loss from recurrence of FSGS. Younger age at transplantation, as long as it's not inherited FSGS or genetic FSGS, we would not expect genetic FSGS to recur because the problem was in the podocyte. You're giving them a normal kidney with normal podocytes. So as long as it's younger age at transplantation in those patients who did not have genetic forms of FSGS, those are patients that would be at risk for recurrence. Heavier proteinuria at original diagnosis, more rapid progression to ESRD. And interestingly, if you're an ESRD patient from FSGS and you get a living related donor kidney, the allograft survival on average is equivalent to a donor recipient pair from a cadaver kidney. Said a different way, we generally think of living donor transplants as being superior to cadaveric kidney transplants. But that survival advantage, at least on average, is lost in the, let's call it, real FSGS patients that have ESRD. Okay. Remember, FSGS is a wastebasket term. FSGS from, obesity would not recur, right? So, but we're talking about FSGS from that unknown circulating permeability factor. That's the FSGS that has a chance of occurring, okay, not the adaptive FSGS or the hemodynamically mediated FSGS, hyperfiltration FSGS. Okay, diabetes recurs in most patients post-transplantation, diabetic nephropathy, that is. But usually, you can control the diabetes and the risk of allograft loss from recurrent diabetes. It does happen, but it's rare. Okay, certainly if you pitch the patient wisely, the motivated patient who's going to take care of their diabetes post-transplant, that would minimize that risk. Membranous has a risk of recurrence. It's unknown what the value is of checking PLA2 receptor antibodies pre-transplant. Some centers have tried that to incorporate that in their pre-transplant testing if you have PLA2 receptor antibody membranous nephropathy. But generally speaking, the rate of allograft loss is low, okay? Even if it does recur. Atypical HUS and dense deposit disease and C3GN, these are those mutations, these are those defects in complement regulation. Depending on the defect, some may predict 100% risk of disease recurrence. A classic for that would be factor H mutation. Factor H is a regulatory protein for complement, and that's produced by the liver. And so if you take a patient and you transplant their kidney without fixing the underlying problem with factor H, then you would be predicted to blow that kidney out of the water again. Okay, so some individuals, so for instance, factor H mutations or mutants, actually are listed for kidney and liver transplantation in order to cure the underlying defect in complement regulation. Okay, some others would be relegated to post-transplant complement inhibition. That would be an extensive approach because 6 months of complement inhibition therapy is like $500,000, and then would be indefinite if you did not, fix the underlying liver problem. All right. Other forms of complement regulation, let's say here, are unlikely to recur. For instance, the CD46 abnormality. That's a mutation or an abnormality in a tissue bound regulatory factor, right? This is a surface molecule on endothelial cells, amongst other cells, that regulates complement. And so if I give you a new kidney with normal CD46, then you would expect that mutation would be a non-issue, right? So they should not have a disease recurrence if you gave them a kidney with an intact CD46. Okay. Here we've talked about several concepts. I've given you a little more details. Factor H is not the only complement regulatory factor. There's a multiplicity of regulatory factors. So we typically look for these mutations pre-transplantation and make decisions about combined kidney liver transplantation with that information in hand. Okay. You can also look for autoantibodies to these complement regulatory factors. They're so-called nephritic factors that might also be worth considering in pre-transplant testing. Those C3 nephritic factors, if you know somebody has these acquired forms of complement dysregulation. Primary hyperoxaluria is a problem, an inherited problem in oxalate metabolism, and would be expected to recur in the allograft, and would be an instance in which liver transplantation is essentially always done with kidney transplantation and primary hyperoxaluria. I have to hedge because now there is a mRNA-based therapy that can inhibit some of the biosynthetic steps to oxalate metabolism. Okay, so there is a drug that's available for treating primary hyperoxaluria. That's extremely effective. It would be, again, pretty expensive to relegate a post-transplant patient to a lifelong treatment with that RNA inhibition therapy. Okay, waiting times. It based on a history of malignancy is an area of nuance. Okay, so if you've had a history of malignancy, for instance, a renal cell carcinoma, that would be a classic one. That information feeds forward into decisions about active listing. Okay, so you can take a patient who has a cancer, let's keep it general, and that cancer is presumably cleared. You can put them on your wait list, but you can list them as inactive. The advantage of doing that would be they get to start their wait clock. Okay, but you're not going to transplant them. You're going to list them as, they call it status 7. So you're on the list, but you're inactive. So you get to accrue wait time, but you're not made active until you've reached a reasonable number of years to provide reassurance that you're not at risk, or your risk for cancer recurrence is low. That is a very nuanced decision. One of the tools that's used for this, you may hear about, is this Israel Penn tumor registry. It's named after I believe he was a transplant surgeon, Israel Penn. And it gives you risk of disease recurrence according to cancer attributes. So in this tumor registry, you'll put in renal cell carcinoma of this size with negative nodes. What is the likelihood for disease or cancer in the post-transplant patient? So this tumor registry is used for making some of those decisions. Okay. That being said, there's a general principle if you want to approach it in broad strokes. 2 years of no detectable disease, and no evidence of disease. You'll see NED in your oncology notes. Even in patients with PTLD, 2 years is a round number. Now, there's exceptions to that in skin cancers, basal cell carcinomas that are shaved off, or superficial squamous cell carcinomas. Those are often, again, no wait time. Okay, in situ bladder cancer that is addressed, and then even small renal cell carcinomas, right? Those small, less than 2 centimeter renal cell carcinomas that are confined to the capsule. Those would be surgically cured with no chemotherapy, for instance. Many of your urologists will even sit on those and say, yes, you have renal cell carcinoma, but we're just going to put you on a surveillance protocol and follow you with yearly imaging. Those are considered low risk for metastasis. So those are the instances that can be addressed by nephrectomy with no wait time. Okay. Wait of less than 2 years if you have cervical cancer in situ or prostate cancer with low Gleason scores. Wait lists might be extended to 5 years for melanoma, unless it's melanoma in situ, colon cancer with Duke stage B1 or better. Okay, you might consider, again, a reasonable wait time of 5 years. Sometimes long. I mean, if you're higher than Duke's score B1, you would be essentially contraindicated for transplantation. Large renal cell carcinomas, again, you may have wait. What is large? Depends. Some people use 5 centimeters as a cutoff for what is a large renal cell carcinoma. You're going to have your urologist weigh in on that. Breast cancer with positive nodes, or bilateral breast cancer, or inflammatory carcinoma of the breast. Those would be considered higher wait times, okay, before you would consider active listing. Let's finish off this chapter. Questions? Okay, quickly then, donor evaluations, living donor evaluations. They're contraindications that are absolute and relative. We don't take non-adults, legally non-adult patients and consider them for donor nephrectomy. Obviously, there's plenty of problems with risk of coercion in patients who can't clearly be autonomous decision makers. So even if you're over 18, there's a donor advocate that sees the patient. And that donor advocate is insulated from the rest of the evaluation to make sure there's no clear evidence of coercion. So even an older patient can be considered as not a candidate for transplant if the donor advocate says, I'm worried about this individual understanding the risks of donor nephrectomy, even if they're over the age of 18. Okay. Uncontrolled hypertension. So if you have, or hypertension with end organ disease, if you have easy to control hypertension, one drug, or diet controlled hypertension, even again, hypertension on hydrochlorothiazide, that is not a contraindication for donor nephrectomy or it is if you're a young person. So if you were a 30-year-old on hydrochlorothiazide with well-controlled blood pressure, most people would say, you have too many life years ahead of you. We're not going to consider you. But if you're a 50-year-old on hydrochlorothiazide, yeah, you can donate. Okay, so that's why it's in this absolute. Well, it should say uncontrolled hypertension would be an absolute contraindication, but I guess I haven't put it as a relative contraindication here. But this conversation hopefully conveys that squishiness to hypertension as a barrier to serving as a kidney donor. HIV, that's uncontrolled, or HIV period in a living donor. I guess you can say, I don't know whether the HOPE Act, the passage of the HOPE Act, is translated yet to living donors. So now with the HOPE Act, we're able to consider HIV positive donors, cadaveric donors, as recipients. But I haven't heard of the HOPE Act being forward to considering living donors for transplantation. A HIV positive living donor donating to an HIV positive recipient. Okay. Now this HOPE Act has allowed for that to happen across cadaveric kidney transplantation into HIV positive donors, but I haven't heard of HIV positive living donors being considered for transplantation. Diabetes, absolute contraindication. Malignancies in the donors, psychiatric illness, recurrent nephrolithiasis, a single kidney stone would not necessarily be a contraindication. Sickle cell disease would be a contraindication. Proteinuria, unless, I mean, is a pretty strong contraindication, unless you can document that this is the innocent orthostatic proteinuria. So, some patients, particularly young individuals, can have proteinuria manifest with upright posture, but it goes away with recumbency, and then you usually grow out of that. So proteinuria for any other cause would usually be a pretty strong contraindication. GFRs that are low, arbitrarily 80 cc's per minute, might be considered a cutoff, but the older the donor, the more likely you're willing to push this envelope a little bit, right? Because they have less life years to preserve off dialysis. Okay. If the donor has multiple renal vessels, then you might not be able to list, right? Because it's just too complicated to take the kidney and put it in and do a safe donor nephrectomy. Okay. Active hepatitis B or hep C, recurrent nephrolithiasis, especially if you have overt metabolic risk by 24-hour urine studies, family history of diabetes, especially in the younger individual, might turn you off to entertaining this kidney donor. BMIs that are over 35, each center will have their own institutional cutoffs. Strong family history of renal cell carcinoma, As you can imagine, some of these other things would be pretty obviously barriers to donor serving as a kidney donor. What is the workup of the kidney donor? Fairly routine stuff that you might predict, including fasting blood glucoses in certain people with higher risk features like a strong family history of diabetes. You might also do glucose tolerance tests that are done. Okay. A1C, of course, is another tool. Okay. So here's your glucose tolerance test or A1C. BMIs that are on the higher side might also get these more, you know, additional tests for diabetes or early diabetes. Serologies in the donor are done, including looking for endemic infections in a donor who was from a place with higher risk for strongyloides and Chagas, for instance. Routine cancer screening would be done in the donor. You would do 24-hour urine studies for creatinine clearance, proteinuria, metabolic risk for patients who have risk factors for those. You would do basic cardiac testing, chest x-ray, pregnancy testing. You'll also look at the donor vascular anatomy to, again, assess for these complex anatomies that would be a barrier for transplantation. And then there's also a significant amount of consideration in the PKD patient who has obviously a family history of PKD. And so family members who want to be donors have to be evaluated carefully for their own risk of PKD. So one evaluates that candidate, that prospective candidate, for looking for cysts in those individuals. There's certain ultrasound criteria, also MRI criteria for essentially determining the likelihood that that donor harbors a PKD gene mutation. We'll go over those when we talk about polycystic kidney disease. They're quite solid. Right? There's certain MRI criteria and even ultrasound criteria that have greater than 97% positive predictive value for, I mean, negative predictive value is what you're primarily interested in, depending on features of the prospective donor, their age, essentially. So you can also just do genetic testing on the prospective donor to get an idea of whether there's a risk for underlying PKD in the prospective donor. Okay, questions? We finished that out.